Imagine a patient who walks into the emergency department struggling to breathe. Blood pressure 250/110, oxygen dropping, lungs full of crackles, ECG showing atrial fibrillation with a wide QRS complex. This is not just heart failure. This is SCAPE, sympathetic crashing acute pulmonary edema, and minutes matter. Today's ICU case is about a patient who recovered because the diagnosis was recognized early and treated aggressively. The patient was a known diabetic and hypertensive for more than 10 years, with a previously documented left bundle branch block. Unfortunately, antihypertensive medications had been stopped. The patient presented with sudden severe shortness of breath and a hypertensive emergency. The ECG showed atrial fibrillation with a broad QRS complexes in the setting of a known left bundle branch block. Emergency bedside echocardiography demonstrated a dilated left ventricle and left atrium, an ejection fraction of only 30 to 35%, moderate mitral and tricuspid triggers, and moderate pulmonary hypertension. The ABGs showed a pH of 7.36 with a PCO2 of almost 60 millimeters of mercury, indicating type 2 respiratory failure. The QTC interval was also prolonged to 536 milliseconds. At this point, the diagnosis became clear: acute decompensated heart failure presenting as SCAPE, complicated by new onset atrial fibrillation on the background of chronic left bundle branch block. Now here's an important teaching point. SCAPE is not ordinary pulmonary edema. It is driven by an intense sympathetic surge, causing a sudden rise in afterload. The left ventricle simply cannot overcome this pressure. Blood backups into the lungs, and patients rapidly drown in their own pulmonary edema. The priority is reducing the preload and afterload while supporting oxygenation. Instead of rushing towards intubation, the patient was immediately started on non-invasive ventilation using CPAP. Initial settings were approximately 10 centimeters of water with high inspired oxygen, and oxygen was gradually reduced according to serial arterial blood gases. The patient alternated between periods on and off NIV throughout the night while receiving guideline-directed heart failure therapy. Cardiac biomarkers revealed a high sensitivity troponin of 155 nanograms per liter and an NT-proBNP of 1857 picograms per milliliter. Although the troponin was elevated, the overall picture suggested demand ischemia secondary to severe acute heart failure rather than an acute coronary occlusion. Lab investigations also showed leukocytosis of 18,200 cells per microliter. Urine analysis suggested a UTI, so ceftriaxone was also started with while cultures and clinical monitoring continued. The response over the next several hours was remarkable. The patient produced excellent urine output with aggressive diuresis. Pulmonary congestion gradually resolved. Oxygen requirements fell, and by 7 o'clock the following morning, non-invasive ventilation was discontinued. The patient remained comfortable on only 1 liter of oxygen via nasal cannula. Repeat lab tests showed resolution of leukocytosis, and the repeat trop level had fallen significantly, supporting the diagnosis of myocardial injury related to increased cardiac demand rather than the ongoing infarction. A repeat echocardiogram continued to show an EF of 30 to 35% with left atrial enlargement, moderate mitral rigors, pulmonary mild tricuspid rigors, and pulmonary hypertension. Interestingly, the pattern suggested tachycardia-induced cardiomyopathy, likely related to atrial fibrillation. The patient remained hemodynamically stable, although occasional premature ventricular complexes and paroxysmal episodes of atrial fibrillation persisted. Oxygen saturation remained adequate on low-flow oxygen, and the patient was successfully stepped down from the ICU to the ward. Let's talk about the learning points. First, SCAPE is a clinical emergency where every minute counts. Second, non-invasive ventilation and aggressive overload reduction can often prevent intubation if started early. Third, not every elevated troponin represents an acute myocardial infarction. Always interpret cardiac biomarkers within the clinical context. Fourth, new onset atrial fibrillation can both precipitate heart failure and result from it, and persistent tachyarrhythmias may even lead to tachycardia-induced cardiomyopathy. Finally, guidelines-directed medical therapy, including beta blockers, ARNI therapy, SGLT2 inhibitors, mineralocorticoid receptor antagonists, anticoagulation where indicated, and careful diuresis forms the cornerstone of long-term management of heart failure with reduced EF.